Thank you. Hi, everybody. Thanks, Andy and Lee, for inviting me back. It's great to be here today. So what I thought I'd talk about was, what we see every day at the Young Athletes Center at Mallinckrodt at Washington University in St. Louis. And I liked this title. It's kind of a sleek title, Imaging the Young Athlete with Knee Pain. It sounds cool. But the reality is that what I'm going to talk about is basically skeletally immature patients and the injuries that they get of the knee. So any patient who's skeletally immature coming in with knee pain, no disclosures. So we're going to talk about the various things we see at the WashU Young Athletes Center and go over some of the arthroscopic correlation and some of the post-treatment imaging. It's no longer acceptable to tell the future Tiger Woods or the future Roger Federer or the future whoever to just walk off their injuries. We need to know what's going on so we can establish a physical therapy regimen and start doing the appropriate treatment immediately in order to mitigate any potential future cartilage damage. I mean, most of what these pediatric orthopedic surgeons are trying to do is to prevent future osteoarthritis. And the earlier you can treat these things, the better the patients seem to do. So we'll start with the patellofemoral joint. Patellofemoral joint, you can have longitudinal injuries. They typically occur either at the inferior pole of the patella or at the tibial tubercle, and you can have both chronic and acute injuries at those locations. And then lateral injuries are essentially transient lateral patellar dislocation, which is extremely common. So Sinding-Larsen-Johansson disease has a very long name, but quite simply, it's a chronic traction injury at the inferior pole of the patella at the immature osteotendinous junction. So oftentimes on radiographs, a patient will get a set of radiographs for pain, tenderness at the inferior pole of the patella. You do the radiograph and it's completely negative. And then occasionally they will go on for MRI and you can see this marrow edema that is centered at the inferior pole of the patella. It's also in the soft tissues. The patellar tendon itself looks normal, but the edema reflects the stress changes at that osteotendinous junction. And this is termed Sinding-Larsen-Johansson disease when it occurs in active preteens. So this diagnosis is specific to kids about 10 to 14 years old. In adults, they tend to call it jumper's knee, but in kids, they use this eponym. It can take on various appearances. It doesn't have to be normal at radiography. You can see soft tissue swelling anteriorly, thickening of the patellar tendon, and then dystrophic calcification and eventually ossification at the inferior pole of the patella, which is, again, just reflecting essentially those chronic traction changes, chronic microfractures, probably. This patient was treated conservatively, never did get an MRI, but you can see over time, the inferior pole of the patella, that accessory fragment tends to more solidly ossify. However, it never goes back to normal. In the acute setting, when you have sudden forceful contraction of the quadriceps muscle, fracture at the inferior pole of the patella is called a patellar sleeve avulsion fracture. And essentially what happens is that the patella is surrounded by cartilage, and so you can either fracture just the periosteal covering or just the cartilage covering the patella, but most commonly there's a small crucentic fragment that stays with the patellar tendon while the patella is retracted proximally due to quadriceps contraction. So here we see this crucentic fragment there at the proximal aspect of the patellar tendon and severe patella alta. You can see that the quadriceps, the extensor mechanism is deficient. So these patients need to have these fractures fixated in order to restore function and minimize any potential negative outcomes. So what they usually use is some sort of either radiopaque or radiolucent tension band construct. If it's radiolucent, you'll just see tunneling through the patella itself, and the two fragments will be opposed and heal together over time. But again, the inferior patella will look irregular forever. If a patellar sleeve avulsion fracture goes untreated, as was the case here, so this child lived in a rural part of the state, came in, got the full workup, X-ray, MRI, and then somehow was lost to follow-up. So again, we see this crescentic fragment at the proximal aspect of the patellar tendon, soft tissue swelling, and then associated marrow edema on the MRI in the two fragments of the patella surrounding the fracture here and here. Came back 2 years later, and presumably due to the chronic motion at the fracture site, there's been this exuberant heterotopic ossification. And he was doing okay. The reason he came back is because he was having some pain and grinding with excessive activity. So we did an MRI, and you can see there's not too much edema within the fragments at the inferior aspect of the patella, but laterally in the patellofemoral joint, there's a lot of edema and intermediate signal consistent with synovitis. So he ended up having these fragments retracted to restore more normal feeling in his patellofemoral joint and function. An important variant that you should know about is the scale apophysis, which is essentially an accessory ossification at the anterior aspect of the patella. The patella is surrounded by cartilage, so these little accessory ossicles can form all over the place. This is one of the more common locations. This is not an avulsion injury. If you were in the ER and looking at this case, the fragments are pretty well corticated, and they are located entirely anterior to the lower aspect of the patella. So if you're going to have a patellar sleeve avulsion injury, the fragment is almost always crescentic and more at the antero-inferior aspect of the patella itself. As in this patient who had Osgood-Schlatters, again, you can see the exuberant soft tissue swelling and the fact that that fragment is more obliquely oriented or crescentic. Likewise, at the tibial tubercle, you can have chronic traction injuries. This is Osgood-Schlatters disease. Again, it occurs in active preteens, 10 to 14 years old or so. The radiographic findings are variable. You may or may not see abnormalities. The most important determination of whether they have it or not is if they have tenderness at their tibial tubercle. However, if you do see soft tissue swelling anterior to a fragmented tibial tubercle, that can suggest the diagnosis. On MRI, the patellar tendon may be a little thickened and demonstrate edema-like signal within it. There's typically edema within the tibial tubercle itself and some fluid occasionally in the deep infrapatellar bursa, which all suggest that there's an element of active inflammation going on here. Here's another patient with Osgood-Schlatters disease. You can see instead of the normal fat density in the deep infrapatellar bursa, we see this edema, soft tissue thickening anteriorly. And then occasionally in kids who have had Osgood-Schlatters in the past and reach skeletal maturity, they can have persistent fragmentation at the tibial tubercle. That's not necessarily pathologic. In fact, oftentimes doesn't mean anything. However, it can cause pain, and if they are tender there, despite being skeletally mature, we'll typically get an MRI, and oftentimes you'll see edema within this ossicle, as well as a small amount of fluid in the deep infrapatellar bursa. You can see that the patellar tendon itself anterior to the ossicle looks relatively normal. There's no abnormal thickening or signal within it, so he'd be a good candidate for resection of this small ossicle, and he did have resolution of his symptoms after resection of that ossicle. And similarly, you can have an acute injury at the tibial tubercle, the avulsion fracture. So again, this is due to forceful contraction of the quadriceps musculature, and basically the patellar tendon remains attached to the tibial tubercle and fractures through the physis, which is, physes in kids are anywhere from 2 to 5 times weaker than the tendons and ligaments, which is why they tend to fracture through their physes rather than develop tendon ruptures, or one of the reasons. So this is a displaced tibial tubercle avulsion fracture. These are typed according to the Ogden classification system. So a type 1 would be essentially extraphyseal, so you have a variably sized small fragment at the tubercle, which is minimally displaced. Type 2 fractures extend to the proximal tibial physis, and then type 3 fractures extend through the epiphysis to the articular surface of the tibia. Type 1 fractures can be treated conservatively, but type 2 and 3 typically will require some sort of screw fixation. So that third patient had reduction and screw fixation of his avulsion fracture, and it had already healed quite nicely 3 months postoperatively. All right, moving on to lateral patellar dislocation. This is by no means unique to pediatric patients, but we see so much of it, I felt it should be included here. So the typical findings on radiography of lateral patellar dislocation are somewhat heterogeneous. You may or may not see soft tissue thickening medially. If you're lucky, you may see an osteochondral fracture at the medial aspect of the patella, as in this patient who had that fracture of the medial patella with the fragment in the lateral joint space. The patella is somewhat subluxated, and there is soft tissue swelling medially. Most of these patients, if they're chronically unstable or have severe pain after their first dislocation, will get an MRI. And the classic bone marrow edema pattern for lateral patellar dislocation is marrow edema at the medial aspect of the patella and at the lateral femoral condyle, which you can sort of see here. This is that same patient who had that prior radiograph. So we see, again, the osteochondral fracture at the medial aspect of the patella and the fragment in the lateral aspect of the joint space. When you're looking at MRI for lateral patellar dislocation, at least at our institution, there are basically 3 things that the orthopedic surgeons care about, and it's all based on the surgery that they do to help these patients if they are failing conservative treatment. So the first thing you want to look for is the integrity of the medial patellofemoral ligament and medial patellar retinaculum and the other medial supporting structures, and then the relative lateralization of the tibial tubercle, and finally any intra-articular bodies that they either need to fix in place if they're large enough or just remove. So residents often have trouble finding the MPFL on MR images. There are a few tricks you can use to find it. You can see it's a horizontally oriented ligament that connects the medial epicondyle of the distal femur to the upper portion of the medial patella. On MR images, if you're scrolling through axial images, it starts just after the vastus medialis obliquus muscle kind of peters out, so that's a good indicator. You can also see that it originates and attaches sort of at the same place as the medial collateral ligament, which is another good indicator for the femoral attachment of the MPFL. So here is a normal MPFL on an axial image. It looks like any other ligament connecting the medial epicondyle of the distal femur to the patella. And on a coronal PD image, you can see it's sort of a thickened hypointense structure that's just beneath the VMO muscle and attaches to the superior aspect of the medial patella. It blends in with the medial patellar retinaculum, which is technically considered the inferior ligamentous attachments of the medial patella, but they're all one structure, so it's difficult to sort them out. We don't make the distinction. I just tend to call it all the MPFL. With lateral dislocation, the MPFL is often compromised in one way or another. On this left-hand axial image, you can see the distal portion of the MPFL is very wavy and irregular, and it was completely torn from its femoral attachment, whereas on the right-hand image, it is thickened and irregular, but still remains attached to the patellar portion. And at the femoral aspect, there is a lot of edema between the MPFL and the femur, suggesting that it has been sort of stripped off its femoral attachment or partially torn in some way, and that patient did go on to get repair. Lateralization of the tibial tubercle is an interesting topic. The way we kind of quantify that in our reports, and I think what a lot of orthopedic surgeons use is the tibial tubercle trochlear groove distance. So what that essentially is if you superimpose the tibial tubercle on top of the trochlear groove here, draw a line draw the posterior condylar line along the posterior aspect of the femur, and then draw two perpendicular lines, one of which bisects the patellar tendon attachment on the tubercle, and the other one which bisects the deepest portion of the trochlear groove. That the distance between those two lines, as measured along the posterior condylar line, is the TTTG distance. Generally, less than 15 millimeters is considered normal, and greater than 20 millimeters is considered abnormal. As the tubercle becomes too far lateralized, the patella has a propensity to sublux and dislocate laterally. So that suggests that they may benefit from a medialization procedure, a distal realignment, which I'll go over shortly. Intra-articular bodies look like they do anywhere else. You can see them all over the place. They can be large osteochondral fragments, as on the left, or smaller chondral fragments, as on the middle image. And that right-hand image is the same patient we had seen earlier. Just a brief note on trochlear morphology. We don't make too much of a deal about this. There are a lot of different angles and inclinations and ratios people have reported to try and quantify trochlear morphology, but at least our surgeons don't really care unless it's markedly abnormal, as in this patient on the left who has a convex trochlea and basically no medial facet. The patient on the right here, on this axial T2 fat sat image, came in with patellar grinding and pain and had a sessile osteochondroma just above the lateral aspect of the trochlea, so that was resected and they had resolution of their symptoms. So the reason they care about those three different things is the surgery is basically a three-pronged approach. They basically tighten up the medial soft tissue structures in some way, either through retinacular suturing or advancement of the vastus medialis obliquus muscle to more advance it distally and medially to strengthen the medial supporting structures. Lateral release, which is essentially exactly what it sounds like, a release of the lateral retinaculum to release any lateral tension, and then some sort of distal patellofemoral realignment. If the patient is nearly skeletally mature or skeletally mature, they do medialization osteotomies of the tibial tubercle. But if the patient is 8 years old or 9 years old and they're having severe patellar instability, can't really cut off the developing tubercle, so they will actually just strip the patellar tendon from its distal attachment and realign it more medially along the tibia, so off the tibial tubercle, which is what they did in this case. So this was an 8-year-old girl with habitual dislocation, which means with every cycle of flexion and extension, she was dislocating her patella. Usually they have relatively severe anatomic abnormalities. Hers weren't too bad. Her trochlea was essentially normal. You can see that the patella is kind of sitting up high on the femur here, because at the level of the patella, we don't see any evidence of the trochlea. It is subluxed laterally. The TTTG distance measured 28 millimeters, which is considered abnormal. So the blue arrow is pointing to the tail end of the vastus medialis obliquus muscle fibers, and so that black line extending anteriorly from it is the MPFL, which looked normal. She had some marrow edema at the lateral aspect of her lateral femoral condyle, and incidentally, it's on the image, so I have to show it. She had a giant cell tumor of the tendon sheath there, but she ended up going to surgery. So before they do surgery in anyone who's skeletally immature and they're thinking about potentially realigning bones or disrupting physes, they will get a standing AP view of the bilateral lower extremities to check for any existing leg length discrepancies or angular deformities. You can see here she has bilateral genu valgum, which was probably also contributing to her patellar instability. And then we just verify a bone age with a AP radiograph using the standard Gorlick and Pyle method. So post-op, there's not much to see. They put in her medial 8 plates with screws to try and shut down the medial aspect of that physis and correct the genu valgum. And then on the right side, where she was habitually dislocating, they did end up doing a patellar tendon transfer. So they moved it over about 100%, or about a complete width of the patellar tendon. Here's an older patient who had, the similar type of surgery. So they had the lateral release. You can see that the lateral retinaculum is irregular, and there's a defect within it. The vastus medialis muscle and medial MPFL are thickened and irregular, consistent with prior medial tightening. And then she had a tibial tubercle osteotomy, and you see the susceptibility artifact from the screws related to that. And her TT-TG distance was reduced to 2 millimeters, and she was stable throughout flexion and extension. Moving on to the cruciate ligaments. I'm not going to talk about the posterior cruciate ligament today. It's the strongest ligament in the knee, and it rarely tears in sports injuries. It requires a pretty gruesome mechanism to tear. However, kids can get all different types of anterior cruciate ligament injuries. Proximal avulsion fractures are quite rare. More commonly, we see intrasubstance tears and distal avulsion fractures. In the past, intrasubstance tears of the anterior cruciate ligament were thought to be pretty rare in kids, but as we've started MRing a lot more of these kids and evaluating them more aggressively, the incidence has definitely been rising over the past decade. And as a result of that, they've come up with some new methods for repairing ACLs in kids who still have a lot of skeletal growth left. And we'll talk about that, but it's pretty interesting. The standard techniques that were used in the past are not favored in these kids because you have to drill through the physis, basically. So again, proximal ACL avulsion fractures are strange. They require sort of a strange mechanism. This was a 6-year-old girl who was not happy while getting this x-ray. So this is supposed to be a lateral knee. In kids, we kind of take what we can get. In this case, it worked out actually for our benefit, because you can see a small osseous fragment in the notch there. Hard to know exactly where that's coming from on the basis of this radiograph. So she went on to get an MRI. And you can see at the femoral footprint of the ACL, there's a minimally displaced fracture. So this was a proximal ACL avulsion fracture. On the sagittal PD sequence, you can see that thickening and irregularity of the ACL proximally there. There's really not much written about the treatment for these injuries. This one was very minimally displaced, so she was treated conservatively and did well. But there's no consensus on how to treat them. Intrasubstance ACL tears in kids are diagnosed exactly the same way as they are in adults. So you're looking for fluid signal in the ACL, or thickening and irregularity of the ACL, or absence of an ACL where an ACL should be, as in this, I think, 9-year-old soccer player. Here's another example, 9-year-old boy with an intrasubstance ACL tear. You can see that the course of the ACL is more horizontal than you would be expected. Typically, it would closely parallel Blumensatz's line, which is this osseous line at the intercondylar notch here. And this patient was insufficient clinically. And so if you have an intrasubstance ACL tear, there's a few different reconstruction methods you can use. The traditional approach has been transphyseal reconstruction, and that's fine for patients who are skeletally mature or nearly skeletally mature. They either use usually hamstring autografts or bone patellar tendon bone autografts to reconstruct the ACL. However, about a decade ago, Doctors Coker and McKelly at Boston Children's Hospital came out with the iliotibial band reconstruction, and I'll get into what that is. It's a physeal sparing technique, which is occasionally used at our institution. The one we most commonly see is the all-epiphyseal or all-inside reconstruction, which is basically reorientation of the femoral and tibial tunnels to avoid the physes. So this is just an example of a transphyseal reconstruction, which was performed in someone who was essentially skeletal immature. I think it was a 15-year-old boy. This is the normal orientation of the tunnels that you would want to see. So the femoral tunnel entrance, which is a little difficult to see here, but it's located roughly at the intersection of the physis and the posterior cortex of the femur. The entrance of the tibial tunnel is located posterior to Blumensatz's line, and they used suspensory fixation with a button in the femur and then an interference screw down in the tibia. So iliotibial band reconstruction is not anatomic, as you'll see in a second. However, despite that, the outcomes have been very good. They have a less than 5% failure rate. I've seen a handful, and they've all done well. They've followed many of these kids to skeletal maturity. None of them developed significant angular deformities or limb length discrepancies. However, given that it's non-anatomic, it's typically reserved for prepubescent patients, so Tanner stage 1 or 2, very young kids who may have reasons that they can't get the epiphyseal reconstruction that I'll talk about in a second. So this was a 6-year-old girl who had a partial ACL tear. It was insufficient clinically, so they decided to so what they do actually is harvest about 15 centimeters of the iliotibial band. You can see on the MRI that it remains attached to Gertie's tubercle laterally. Full disclosure, the operative images are not of the same patient who is in the MR, but this patient is a really nice example because there's a large joint effusion that allows you to highlight the anatomy, and the anatomy looks the same regardless of which patient it is. This is just demonstrating the normal appearance. They basically suture the iliotibial band to the lateral aspect of the lateral femoral condyle at the intermuscular septum, wrap it around the back of the femoral condyle so you can see it outlined by the joint fluid here. This is the iliotibial band coming around the condyle there, and then loop it back through the intercondylar notch from lateral to medial to try and approximate the course of the normal ACL. They thread it under the intermeniscal ligament and attach it subperiosteally at the proximal aspect of the tibia here. So this is really the normal course of this graft, and you can see in the notch on the coronal view it looks pretty normal. However, on the sagittal view, it essentially abuts Blumensatz's line, and it's slightly bowed at the anterior aspect of Blumensatz's line here. Despite that fact, the patients have done extremely well. Their functional scores have been very high postoperatively. To the right here is a cartoon just depicting maybe more clearly what they're actually doing. But the whole purpose of this is to restore ACL function while preserving the physes to allow for full growth of the skeleton. In patients who are a little larger and in whom have large enough ossified epiphyses that you can actually drill a tunnel through, so the tunnels they drill are about 7 millimeters, so you need at least 9 millimeters of bone or so to be able to drill through that. They prefer doing this all-epiphyseal reconstruction, which is a nearly anatomic. So during their operation, they check to make sure that the course and tension on the ligament is essentially normal. Again, this has had good outcomes used in older kids, so that's what this child ended up getting, who had a complete ACL tear. Again, we will do standing bilateral lower extremity radiographs to check for any existing length discrepancies or angular deformities, and then verify the bone age using the Groylik and Pyle method. So here's a construction of the femoral tunnel. Basically, this is the orientation of the femoral tunnel. You can see it's extremely horizontal. They plan it to be a few millimeters distal to the femoral physis at the posterior aspect of the notch, near the anatomic location of the ACL footprint. They thread some strings through it and then drill the tibial tunnel, which is also very horizontally oriented. That's entirely within the proximal epiphysis of the tibia. Once they have their tunnels drilled, someone else will have been harvesting hamstrings to use as the graft. So typically they will harvest the gracilis and semitendinosus tendons and form kind of like a 4-strand hamstring autograft, and they pull the graft retrograde through the intercondylar notch and fix it, usually with suspensory fixation in the distal femur and then some sort of screw and post fixation in the proximal tibia. So again, you can see that the coronal orientation of the graft is probably nearly anatomic. However, the tunnel positions are markedly horizontal to allow them to avoid damaging the physis. So there's the articular orifice of the femoral tunnel and the articular orifice of the tibial tunnel. They're in relatively normal positions, distal to the physis in the femur, obviously, and then this cartoon on the right again depicts what this looks like. And those patients do pretty well. So distal avulsion fractures, much more common than proximal avulsion fractures. You can have different types. The Myers and McKeever classification system is what most people are using. So a type 1 fracture would be a small fragment that's minimally displaced. A type 2 fracture kind of trapdoors up anteriorly and remains kind of hinged posteriorly. And then type 3 are fractures that are completely displaced from the proximal tibia. So when the displacement is not too great, they can try conservatively casting. These kids, they use axial compression to try and push the fragment back into place and then cast them in position with axial compression. But the majority of these patients, since this is an intra-articular fracture, will get an MRI at our institution. They can be very subtle on radiographs. So here, you see the Sagan fracture, which is helpful, but oftentimes when these avulsion fractures hinge up anteriorly, their margin kind of parallels the femoral condyles. So if you're not looking for the fact that there's no normal tibial spine here, it's very easy to walk over this. The fracture fragment is actually huge, but it's hidden by both femoral condyles. So this is the MRI in that patient. We will typically get MRIs to confirm the degree of displacement and then confirm the number of fragments and which structures are attached to which fragments. So here there's a large medial fragment, a smaller lateral fragment, and then you can see that the anterior horn of the lateral meniscus attaches down onto that smaller lateral fragment. Here's a larger fragment which is more severely displaced, and one of the things that the surgeons are interested in is if there's anything that could potentially block their reduction. So when the fragments are smaller, they will occasionally try to treat this conservatively, but here, for example, you can see this is resting on top of the intermeniscal ligament, so that will need to be repositioned at arthroscopy. And then again, the anterior horn of the lateral meniscus is attaching down onto that. This was another type 3 fracture in a 9-year-old boy, so the fragment is completely displaced away from the tibial epiphysis, and they were having trouble reducing it, so he got an MRI, and you can see the displaced fragment there. It's fairly subtle. It's just a thin cortical bone, essentially. And in between the fragment and the remaining tibia, there's often intermediate signal. It's usually hemorrhage or fibrosis or a mixture of the two. Here you can see that the intermeniscal ligament is anterior to the fragment. Despite that, when they went in for arthroscopy, you can see a lot of soft tissue underneath the fragment here, so that all had to be debrided and cleared away, and they basically lasso the distal portion of the ACL, drill a small hole through the tibia, and then fix it with a button anteriorly. So this is the postoperative image in that patient. You can see that the fragment is completely reduced, and all that's left is that button at the anterior tibia. So these are the things that the surgeons always ask about when we MR these fractures. So size and position of the fragments. Do they involve the articular surface? What's the relationship to the intermeniscal ligament? And what other structures are potentially attaching to these fragments besides the ACL? Not too much to say about meniscal tears in kids. The criteria is the same as in adults. Isolated tears of an otherwise normal meniscus are extremely uncommon in children under 10 years old. Whether that's due to increased compliance of the knee or other factors is unclear, but usually if kids under 10 years old or, significantly but under skeletal maturity are coming in with a meniscal tear, there's some underlying abnormality. They may occur with other injuries. I know this wouldn't be a problem here, but we've had several kids referred for arthroscopy for basically intrameniscal vessels. So up until the early second decade of life, the menisci are fairly vascular structures, and you can see perforating vessels within the peripheral aspect of the medial meniscus very frequently in kids. It's not a tear. It does not contact either the tibial or femoral surface. Sometimes on a PD sequence, on a proton density sequence, there is associated abnormal intrasubstance signal with these vessels, but this is not a tear. This is a very common location for basically vascular changes in young menisci. If we do see tears, it's usually in the setting of a discoid meniscus, which is, as everyone knows, basically a meniscus that is too large. The MR criteria for a discoid menisci are relatively well established. On coronal images, if the minimum width of the meniscus is greater than 20% of the total tibial width, that suggests it's a discoid meniscus. Again, on the coronal images, if you have a minimum width that's over 15 millimeters, that's suggestive of a discoid meniscus. And then on sagittal images, if two of the meniscal horns, the maximal diameter of the two meniscal horns make up more than 75% of the total meniscus diameter, those are pretty sensitive and specific for discoid menisci. The problem is that it's pretty clear that the menisci grow throughout the first decade of life until skeletal maturity. If you look at an MRI of a knee in a 2-kilogram neonate, the meniscus doesn't look enormous. It looks proportional relative to the child. So there is growth that occurs, and it's unclear what the normal volumes of the menisci are at various ages. And sometimes it's difficult to say whether something is a discoid meniscus or not. It's not always obvious. So you just kind of have to use your judgment and the symptomatology of the kids to decide whether to treat actively or not. Obviously, there are different types of discoid menisci. Complete, where the meniscus spans the entire lateral compartment. You'll often see abnormal intrasubstance signal within discoid menisci, likely related to altered biomechanics. However, if the signal does not contact either articular surface, it is not a tear. Incomplete discoid menisci, when it doesn't quite extend all the way across the articular surface. So here's an example of a meniscus that measured 17 millimeters in minimal width. It's bilateral, somewhere up to 50% of the time. This was a child with bilateral discoid menisci, and these kinks at the posterior aspect of the meniscus suggested that it was unstable posteriorly. So this patient was experiencing a substantial amount of locking and pain And when they went in for arthroscopy, the menisci were both extremely mobile. So what they can do is saucerize the menisci to recontour them into a more normal shape and then fix them to the lateral capsule in an attempt to stabilize the menisci to more normal function. Sometimes it's not always clear. So this was a 9-year-old boy who came in with knee pain and locking. You can see that both the horns, the two horns of the anterior and posterior horns of the menisci are very closely opposed. In fact, it's almost overlapping. If you were scrolling through this quickly, you could mistake it for a tear. Really, the posterior horn here is quite anteriorly translated on the tibia. And so when you see this, there is an entity called hypermobile lateral meniscus. It's a very difficult diagnosis to make prospectively, and I think if you try to be too aggressive with it, you'll be wrong just as often as you're right. However, when the meniscus is translated anteriorly in the setting of someone with significant locking and pain, you need to bring it to the attention of the surgeon, even if there's no obvious tear on the images. Some secondary findings that can be helpful for diagnosing a hypermobile lateral meniscus would be absence of these posterior popliteal meniscal fascicles, which basically are 1 millimeter black lines that extend from the superior and inferior surfaces of the meniscus to the posterior joint capsule. Even in the best of times, they're difficult to visualize, so it's not always reliable. This meniscus, you could see, was kind of kinked at the posterior horn-body junction here on the axial image. And then there was a meniscofemoral ligament of Humphrey present, so there was some sort of stabilization in the back. He did end up going to arthroscopy because of his symptoms. Turned out when the knee was fully extended, which is how we image them at MRI, the meniscus kind of bunched up on itself, so it was almost like a very prominent meniscal flounce. And then when the knee was brought into flexion, it looked completely the meniscus looked completely normal. So here on the right-hand image, probing the free edge of the meniscus here, this is the meniscus, and it's just completely normal, no tear. They didn't think it was especially hypermobile, so actually nothing was done for this child. Here's an example of a more obvious tear in a discoid meniscus. So there's a radial tear at the anterior horn body junction, and it extends, partially across the diameter of the meniscus there. They went to surgery and they saw a radial tear extending approximately 1/3 of the way through the meniscus, and so they kind of trim it down and try to recontour the discoid meniscus to approximate a more normal shape. Here's another more obvious tear. So the anterior horn has basically bucketed posteriorly. It's flipped posteriorly, and it's displacing the posterior horn here. And this patient went for arthroscopy, had the tear resected and repaired, and they tried to recontour a meniscus as best they could, but it can be tricky. And a year later, she came back with relatively minor trauma, and you can see, there's not much anterior horn left. The posterior horn is here. She has this new large, full-thickness cartilage defect. And, it's sort of an art form trying to recontour these menisci to normal shapes and sizes, especially if they're not skeletally mature. So a lot of these kids end up in the future developing cartilage defects and early osteoarthritis. So in order to attempt to restore some uniformity to the articular surface, they do arthroscopy, they go in, they evaluate the lesion. So there's that huge defect. You can see there's a delaminating flap superiorly here. So they ended up resecting that thing. And then they do micro drilling, which basically they drill up into the bone marrow to allow the bone marrow to bleed into the cartilage defect, and that promotes healing and generation of basically fibrosis, fibrocartilage, hyaline cartilage. And then, 3 months post-op, you can see she still had the marrow edema, but the defect was beginning to fill in with at least allowing for uniformity of the articular surface in the hope that her pain would decrease, and she was having decreased pain. So last section here, bones and cartilage. So physeal stress injuries are pretty common. They're more commonly seen, in baseball pitchers, in the proximal humerus, and in gymnasts, in the distal radius, but you also see them around the knee. Basically what they look like is increased T2 signal on the metaphyseal side of the physis. You don't very often see increased signal within the physis itself. The edema is pretty much always on the metaphyseal side of the physis, and there's some thought that these chronic microfractures that are occurring at the physis and leading to inflammation and potentially even small areas of ischemia are essentially interrupting normal ossification in that location, and so you get persistent cartilage and chondrocytes basically leaking into the primary spongiosa of the bone, accounting for this increased T2 signal. So it's not purely marrow edema, it's actually, the physis, the chondrocytes from the physis not being able to undergo calcification and ossification. And so it's important to distinguish stress injuries from what's called focal periphyseal edema, or FOPES. This was originally described by Patellar out of Cincinnati, and she noticed that in a lot of patients who were nearing skeletal maturity, they were seeing these areas of focal marrow edema on both sides of the physis. It always seemed to be central, and it was always in kids who were nearing skeletal maturity. And so it's considered a normal variant. There's some suggestion that it may be a cause of pain, although that's not been conclusively proven. So I think for now we can consider them normal variants. It's essentially, altered biomechanics or stress changes at the physis as it's ossifying. And so stress injuries tend to be eccentric, whereas FOPE zones, as they're called, are central or minimally eccentric. As I said, the marrow edema of stress injuries, or the T2 hyperintensity of stress injuries, is always on the metaphyseal side of the joint. FOPE zones are centered around the physis, and then stress injuries obviously can occur at any age. FOPE zones specifically occur in patients who are nearing skeletal maturity, 14 years old or so. Occult fractures we will occasionally see. So, on the left we have a radiograph of the left knee, which is essentially normal. If you look at the physis, the distal femoral physis on the MRI, you can see elevated T2 signal within it as compared with the proximal tibial physis, and then more medially at the distal femoral metaphysis, there's a hypointense fracture line. So this was a radiographically occult, non-displaced Salter-Harris 2 fracture. And we'll finish up with juvenile osteochondritis dissecans. Now, we have some radiographs of some OCDs here and some corresponding arthroscopic pictures. If you're thinking to yourself, I'm no musculoskeletal radiologist, but that doesn't really look like a knee joint that I'm familiar with. Good job. This is the stifle joint of a horse. So it's basically the upper knee of a horse. And as it turns out, OCDs are extremely common in large animals. They tend to occur in tall animals, like horses get them in their stifle joints, and giraffes get them in their neck. And as a result, if you do a literature search on OCDs, the vast majority of what you'll find that's new is coming out of veterinary medicine, and they know it. So they feel like they've conclusively defined it as a failure of endochondral ossification at the epiphyseal articular complex. In humans, we're a little less specific. So the ROC group is a multi-institutional group which we're a part of at WashU that looks at osteochondritis dissecans in the knee. And it's defined as focal idiopathic alteration of subchondral bone with risk for instability and disruption of adjacent articular cartilage that may result in premature osteoarthritis. Basically, what that means is that the secondary physis, which surrounds the epiphysis, is, for whatever reason, microtrauma, repetitive trauma, the maturation is disrupted, and it results in subchondral abnormality, replacement of the subchondral bone with fibrovascular tissue, and then eventually fragmentation, which may or may not heal and can lead to osteoarthritis. So overall, osteochondritis dissecans is pretty rare. We only use the term osteochondritis dissecans in skeletally immature patients. At WashU, I think that given all the veterinary literature and the human pathologic studies to date, it's pretty conclusive that the abnormality is at the secondary physis. So this is an entity that occurs in skeletally immature patients. You can obviously get osteochondral fractures, osteochondral lesions, and osteochondral injuries in adults. We occasionally see them in young skeletally mature patients. Obviously, probably most of those patients had undetected lesions and then, for whatever reason, became unstable and became symptomatic later in life. So osteochondritis dissecans, or juvenile osteochondritis dissecans, occurs in 10 to 15-year-old kids. And it's in active kids. It's about twice as common in boys as in girls. And the classic location is at the lateral aspect of the medial femoral condyle, as demonstrated on this radiograph here. So the findings that you typically see are basically subchondral lucency. Eventually, you may see some calcification and ossification in the area of subchondral lucency, and over time, if it's healing, it will solidify. The articular surface, or the surface of the subchondral bone, often does not return to a normal contour, but the overlying articular cartilage, as long as that's okay, then they're more conservative with the treatment. So obviously, to look at the overlying articular cartilage, you need to do an MRI, which we frequently do. On radiographs, it can be difficult to distinguish JOCDs from ossification variants. I'll go over some key differences in a bit, but the patient on the left, that's an ossification variant. The patient on the right has a JOCD. Obviously, the JOCD looks more lytic and irregular, which is the more classic appearance of JOCDs, but you can see fragmentation or in situ fragments with them, and so it can be difficult to distinguish the two, but we'll go over how to do that. So again, Tal-Leor, taking a cue from the veterinary literature, decided, well, if this is a disruption of endochondral ossification at the secondary physis, then, on 3T MRI, we can kind of see the secondary physis. So if the secondary physis is disrupted over an area of subchondral, abnormal subchondral bone, then that's probably a JOCD, whereas if you can see the secondary physis intact over the subchondral bone, that suggests it's an osseous variant. So this is an MR image from a normal knee, just demonstrating the normal articular structure or cartilaginous structures that you see. So the straight white arrow is the distal femoral primary physis. The black arrow is the thin, hyperintense secondary physis, which surrounds the epiphysis. The asterisk is the unossified epiphysis, and then the curved arrow is the articular cartilage at the peripheral aspect of the physis. So in this patient who had the ossification variant, you can see that very large fragment at the posterior aspect of the lateral femoral condyle. If you divide the condyles into thirds on the sagittal image, very often ossification variants will be in the posterior third of the condyle, whereas JOCDs will be in the middle third or bridging the middle and posterior thirds. So you can see that this abnormality is entirely within the posterior third of the condyle and faintly see the overlying secondary physis, which is intact. On the T2, on the fluid-sensitive sequence, there's absolutely no marrow edema associated with this thing. So this is just an ossification variant. This patient actually had a hyperextension injury on a trampoline, so you can see the marrow edema, at the anterior aspect of the tibial epiphysis and at the anterior aspect of the femoral epiphysis. Incidentally, he had another normal variant that we see all the time, which are these focal areas of T2 hyperintensity in the unossified epiphyseal cartilage. Some people think that that's basically a precursor of ossification, so that's an area of cartilage that will be undergoing ossification or is extremely metabolically active and is undergoing ossification in the near future. It was first described in the trochlea of the elbow, but if you start doing a lot of MRs, you start seeing them all over the place, and more than likely that's what it represents, or it's just some other benign variant. Whereas here's an example of a JOCD. So on the radiograph, you see the irregular subchondral lucency, and on the sagittal MRI, you see the T2 hyperintensity beneath the lesion here, and this thickening and irregularity of the subchondral bone, cortical bone. So JOCDs tend to occur in older kids, so 10 to 14 years old. Variant ossification is often seen in children under 9 years old. JOCD, you'll either see no fragments or very irregular fragments. In variant ossification, it looks like a puzzle piece. The ossification center will kind of fit into the hole in the epiphysis. If you're lucky enough to see the secondary physis in JOCDs, it is disrupted, whereas in variant ossification, the secondary physis is intact overlying it. And as I said, JOCDs tend to occur in the mid and posterior thirds of the epiphysis on sagittal images, whereas variant ossification tends to occur in the posterior third. JOCDs, you're more likely to see edema, associated marrow edema, and variant ossification. There's typically no edema. So here's a notch view in an 8-year-old showing irregularity of the posterior aspects of both the medial and lateral condyles. That's just normal developmental variation. Here's an MR in that child demonstrating the intact overlying secondary physis next to that area of subchondral signal abnormality. Here's another example of a kid who was imaged for a laceration. So you can see on the notch view that there's the marked irregularity of the subchondral bone posteriorly. Once you've diagnosed a JOCD, you want to classify it as stable or unstable. Stable lesions tend to heal with conservative therapy. Stable lesions in skeletally immature patients do very well. The MR criteria for instability is very well documented. It was, first proposed by DeSmet like 20 years ago, and then they revised it about 8 years ago, separating JOCDs from adult OCDs to see if there was any differences. So these are the criteria that we still use to diagnose instability on MRI. Obviously, an articular cartilage fracture or an existing osteochondral defect. Those are both essentially 100% specific. Subchondral cysts are very specific when you have a single cyst greater than 5 millimeters or multiple cysts in the subchondral bone, as in this patient who had an unstable lesion and numerous cysts in the subchondral bone. Originally, a high T2 signal rim was proposed to be a marker of instability. They revised it that it has to be fluid signal. And then additionally, you may also see multiple breaks in the subchondral bone or an outer rim of T2 hypointensity. All three of these criteria are very specific for an unstable JOCD lesion. So here we see multiple breaks in the subchondral bone, and this, at the white arrow, a line of T2 hypointensity beneath the lesion. So if the lesions are stable, they do conservative therapy. If they're unstable, they can try conservative therapy, but most of the kids end up going on to some sort of surgery. There's 3 main surgeries that they do. Microfracture is probably the most common technique employed. So this was a child with a stable osteochondritis dissecans, and you can see there is a small subchondral cyst, but it's not greater than 5 millimeters, so it doesn't meet criteria for instability. He attempted conservative management, which is basically immobility and limited weight bearing, and failed that. So what they do is essentially drill little holes into the lesion itself to promote bleeding and healing, as I demonstrated with that cartilage defect earlier. And then over time, they tend to do really well, especially if they're younger. They tend to heal very well. So you can see that the subchondral lucency on the left-hand radiograph is now approximated to almost a normal subchondral articular contour 4 months post-operatively, and he was doing very well. Here's an unstable lesion in a kid. It was not diagnosed prospectively as unstable on MRI. You could question whether there are some breaks in the subchondral bone on this coronal T2 fat-sat image here. Obviously, there's some fragmentation, but sort of a borderline case. It ended up that it wasn't really unstable per se. It's what they call a trapdoor lesion, where the fragments are kind of ballooning out the articular cartilage. So if they probed this contour abnormality here, it would be soft. There's nothing for the articular cartilage to adhere to underneath, so they basically that's a risk factor for developing instability. So they ended up fixing the fragments in place. So they drill small screws into the fragments and bury the heads under the articular cartilage, and then additionally do a microfracture to promote healing. And then, so this was 5 months post-op. You can see those 3 screws in place. The fragment is ossifying more solidly, and then 6 months post-op, they removed the screws, and it's basically back to a normal contour. Finally, when the lesion gets bad enough, as in this case where it's almost completely degenerated, the entirety of the subchondral bone is cystic, they may need to do an osteochondral allograft transplant. So this is done open, and they will measure the lesion, ream out the portion of the osteochondral area that's abnormal, and then using a contour matched donor, they will drill a new plug for that hole, basically, and force the plug into that hole. Apparently it's not easy to do. I acted like it was easy to do at one conference and almost got thrown out of the room. So they will delicately put this plug back in place and reapproximate a normal articular surface. And then on post-operative imaging, most people will get post-op studies at 3 or 6 months. You will typically see marrow edema around the transplant, and the interface of the transplanted osteochondral fragment with the normal bone is irregular, but this is essentially what they want to see. I mean, this is almost a normal articular surface. The edema will fade over time, typically by 2 years or so. It's completely resolved. So, sorry, I ran a little bit over, but hopefully you got a sense of the types of injuries we see out there, and as the treatment continues to evolve and become more aggressive, radiology will continue to play a role in the evaluation of these patients. Thank you.